next session. I invite Dr. Syed Kamran Azif for the next session. Sir will be talking about the uncovering the hidden obstruction, pediatric DICE evaluation.
Thanks, Dr. Shankar, for this opportunity to share our experience. So I'll briefly speak about pediatric drug-induced sleep endoscopy, what our protocol is and how we do it. Yeah, so there we go. So special thanks to our team, not just the pediatric ENT, but the anesthesia team as well. But special thanks to the patients and their families who agreed to allow us to use this. So the usual questions comes is when we do DICE, so why should we do DICE? What is DICE? When do we do DICE? And how do we do DICE? The previous speakers have already spoken quite a bit about it. So why DICE? Why should we do DICE? Sleep disordered breathing in children, it's a significant problem. An example is this paper from US where they've looked at a cohort of 13,400 odd children and followed them up at age of 6, 18, 30, 42, 57 and up to 69 months of age. And what they found is in children with sleep disordered breathing, they have significant issues, cognitive delays, school performance, behavioral issues, etc. So what does the American Academy of Pediatrics recommend? They recommend first line of treatment is adenotonsillectomy. Okay, so fine. So we'll do adenotonsillectomy. Why should we do DICE? But the problem here is, if you actually look at it from their own data, so the success of tonsillectomy in sleep disordered breathing is about 60 to 70% in children with hypertrophic tonsils and adenoids. So 30% fail. Whereas in children who are obese, the success rate is only about 10 to 25%. So almost more than 70% do fail. Now the question is, what is DICE? So we had speakers who shared their experience, spoke in detail about DICE. So this is just one kid with big tonsils. Just quickly I'll run through the video, I'll not waste your time. So going through the nose, then the adenoids, partially obstructive adenoids, and just skipping through the velum, the large grade 4 kissing tonsils. Then just behind the tonsil we sneak down to look at the base tongue, epiglottis and the arytenoids. So when do we do DICE in children? So the three indications what I can think of. One is someone who's already had a adenotonsillectomy but has failed surgery. One of that 30% in a kid with big tonsils or adenoids, or the other kids, the second indication is children with small adenoids or tonsils. So symptoms are out of proportion to the findings. And third is of course syndromic kids like children with Down syndrome or any other syndrome. So this is a 4-year-old with Beckwith-Wiedemann syndrome. He's got small tonsils. But if you see on DICE, the adenoids are partially obstructive, still does not explain the symptoms, AHI of 5. That's the velum. You can see a velum collapse as we see adenoids aren't big much. And as we go down, tonsils aren't big either. So that's the velum. You can see the significant velum collapse. So these were grade 1 to 2 tonsils. But now during the sleep you can see they've become 4. They've become kissing tonsils. So there's a significant tonsillar collapse as well. So this is what DICE unravels. So what we clinically see as grade 1 to 2 tonsils, but see when we see that during DICE, we see a significant difference in that. So again, how to do DICE? So when we do DICE, I can look at 3 possible challenges. There are of course the 3 major challenges are, one is plane of sedation. So when I do DICE for one child and repeat it on a different child, or this child comes back for persistent symptoms, how do I ensure my plane of sedation is same? Like sir said, BIS is not it's not a holy grail. It is only a ballpark figure. That is not enough for us to establish a standard. So how do we establish a standard? Second thing is, when an observer looks at the sleep endoscopy video, my finding should be same as someone else's finding. So that should be standardized. And third is, when you have multi-level obstruction, so let's say someone who's got huge adenoids or has enlarged turbinates, they have a arytenoid collapse. So, or an epiglottic collapse. Do we really are confident that there is significant epiglottic collapse? You do a epiglottopexy or a supraglottoplasty. So these are the clinical challenges what we face. To standardize, what we do is we have a anesthesia protocol where ENT. So I can share this protocol with whoever is interested. So what we do is a Friedman tonsil grading, pediatric sleep questionnaire, overnight pulse oximetry. We don't routinely do sleep study for routine adenotonsils. And this is a sleep video, what we usually ask the parents to do. So this is a kid, you can see significant obstruction, apneas, chest retraction. This is all recorded by the parents. So every child who undergoes a DICE has a sleep video recorded by the parents. We ask them to cover the face, the neck, the chest, and it should be at least 3 minutes long. That is not something which is there. We need a much longer video, but at least what we can expect the patients to record is about at least 3 minutes. So, and the sedation protocol, there is no absolute or ideal drug for DICE. Each drug has its own advantages and disadvantages. Propofol has higher respiratory depression, so you can actually have patients who go into apneas, give a false positive result. Dexmed is safe, but again has cardiovascular, and especially in children, they remember the procedure. It has this, the awareness of the procedure is there. Sometimes the kids come out, they remember what was done. So that is also a problem. So what we do is, before the child goes for procedure, so the child undergoes induction in the induction room, trichloral transported to OR, and this is the anesthesia protocol. I can share this, I'll just run through, I'm running out of time. And we do not look at the infraglottic airway unless they are symptomatic. We do look for jaw thrust and lateral positioning maneuvers for all these DICEs. No topical nasal decongestants, and of course video documentation with a 2.8 mm flexible laryngoscope. Now the second is subjective. If you look at it, there are various grading systems. The reason why there are various grading systems is none of them capture everything. If you look at adults, if you look at children, there are plenty. You keep looking, everyone has come up with something new because no one is perfect. So there is a pediatric IPOG, International Pediatric Otolaryngology Consensus Group. They came up with this IPSIS scoring system. They've got all these people who had come up with scoring systems and come up with their own scale. I can give you a link to this article or probably even share the article. I'll run through this. So where the nasal airway, the adenoids, the velum, the tonsil, the tongue base, epiglottis, independent of the tongue base, arytenoids, all these are independently graded. So this is a third child who had post-adenotonsillectomy with persistence of symptoms. He had AHI of 5. You can actually see the nose is okay, the adenoids is okay, there's no recurrence of adenoids, post-tonsillectomy status. But if you go lower down, he has epiglottic collapse. So with the jaw thrust, you can lift the epiglottis, go down, see the arytenoid, that is looking okay. So now, we kind of standardize the anesthesia part, standardize our grading part. Now comes is when we have upstream obstruction. Like for example, if you look at the first video, this is a child who had grade 4 adenoids. So if the first video on the left side, that is a routine DICE. So you can see significant arytenoid collapse. So what do we see? Do we really go to supraglottoplasty on this? So what we'll do is we bypass the obstruction. We put a nasopharyngeal airway, bypass the obstruction, and reassess the dynamic collapse. So with the nasopharyngeal airway, the picture on the right, you don't see much collapse there. So that's kind of reverse. So we are rest assured we don't really need to over-treat the patient. Now, if you look at this second video, so one on the left is with nasopharyngeal airway, one on the right is without nasopharyngeal airway. Again, you don't see much of a difference. It means that this patient probably is not going to benefit with adenotonsillectomy alone, might need something else to be done. And again, DICE-directed surgery, all these procedures can be done as DICE-directed surgery. I'll just finish with one last video. I'm nearing 10 minutes. So this is again a kid who had brain tumor bleed, and eventually had significant airway obstruction and was tracheostomy. You can see in the video, he had significant tongue base collapse. So what we did was, we did a base tongue midline glossectomy and an epiglottopexy, and successfully decannulated with AHI of under 1. and that is his post-op. So the epiglottis is tethered to the base tongue, and that's no longer collapsing. And in summary, adenotonsillectomy is the first line of treatment. Symptoms do persist. We need to be careful about prepared for recurrence of symptoms or persistence of symptoms. There is potential for DICE-directed surgery. We don't want to do multiple procedures on these children. But then again, we have to be careful not to overtreat, not to do unnecessary surgery what is not required. So DICE helps us to do that, but then again, the key is standardization. We don't want to take false positives or false negatives and overtreat or undertreat patients accordingly. Thank you.
Thank you, sir. Wonderful presentation.
Yeah, so CMC has always been a pioneer in many things. You have now put up many protocol things. I wish you can share it in our that they have a WhatsApp group for this Toilcon.
Yes, sir.
That was a good presentation, Dr. Syed.
Thank you,
Thank
sir.
you.
Yeah, we're standing on the shoulder of giants, so that's why we could achieve this.
From the Tamil Nadu Medical University, and I think there is no other universities in India which have actually started a university pediatric ENT program till today. Though we have tried Amrita, Kerala, but I think all of them said there's too much of an effort involved. But I'm very proud of him. He joined my unit as a senior house surgeon after his MS from Baroda. Bhopal. But I identified his surgical and intellectual capacity, and actually I got him on the team based on my retirement post 2 years earlier than my retirement date. That is how I think we are very fortunate. I'm very, very proud of him.
Thank you, ma'am.